بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا اسمي إسلام سمير، استشاري طب طوارئ. We will talk today about the basic principles of disaster management. We have some um, principles to follow when we deal with emergencies or with major incidents. Here we have the sections of our topic today. We will not cover all the sections, but we will have some points to focus on and some points to just mention. The objectives of the lecture: to know the disaster definition and the classification, to know the phases of disaster management, and to know how to respond to disaster when strikes. First of all, what is disaster? The international definition of disaster is major incident, which is more or less unexpected or unexpectable, unavoidable, and it affects mainly the normal discipline of any system, and it may destroy the infrastructure, and you cannot manage the disaster with the ordinary resources. It means you need to move, or you need some extraordinary resources to deal with the disaster. From the definition, if you can expect the disaster, it is not logic to let the disaster occur. If you can expect it very well, you should avoid it at to some extent. But some disasters we know we can expect, as if you have highways in your city or in your country, you can expect there is some RTE will happen on those highways, but you cannot avoid them. Even with all the measures you can provide in these highways to prevent the RTE from happening, it's still a possibility to have major RTE or major road traffic crash or accident. Also, some disasters you can expect, but you cannot avoid. Something like earthquakes, something like floods. You can expect, but you cannot avoid. But if you can expect, you will prepare yourself to deal with the consequences or to deal with the complications happening after the earthquake or after the disaster. We have a lot of classifications for disaster. The main and the most important to us, the main classification is the classification for medical and non-medical disasters. The disaster can be medical if it originates some living casualty. Living casualty means some patients or some victims need medical care or medical assessment. Okay? If the disaster have no living casualty, like aircraft crash, some train crash, some tsunami, these big disasters will leave the scene without living casualty. So the medical facility or the medical authority in the country or in the city will not have any role in managing this disaster, as there is no victims need any medical care. So we have the major classification: medical disaster and non-medical disaster. So the non-medical disaster, the healthcare system has no issue to do with them. Another classification is the type into two types, natural and man-made, and they added one more type, which is technological disasters. Technological, like loss of vital resources like internet, like communication means, like water, like electricity, like this is called technological disasters. The natural disaster is naturally occurring, like earthquakes, like volcano, tsunami, floods, extreme weather, um, like these types, and the man-made, like war, like terrorism, like RTE, and so on. Another classification, depending on the severity, the disaster can be simple, causing less than 50 living casualty, moderate, 50 to 100 living casualty, and severe, more than 100 living casualty. Another classification, depending on the duration. The duration of the disaster itself, not the duration of the response. The duration of the disaster can be minutes, hours, or days. This is called short duration disaster, like the earthquake, like the volcano and the flood. The long duration is usually man-made, like wars, which can last for years. Something like biological threats, like COVID-19, which last for years also. So it's called long disaster or long uh, major incident. Another classification related to the compensation, the disaster can be fully compensated or not compensated at all, or more or less moderately compensated. Depending on the extension, it can be localized in one city or one town. It can be extended to involve more than one city or one state. It can be national, affecting the whole country, or it can be global, affecting many countries. Like the COVID it is global disaster. Like the tsunami, it affects more, maybe 4 or 5 countries. The latest earthquake affected maybe 10 countries. So it is called global, or affecting one country, it is called national. Depending on the complexity, it can be simple or complex or compound. The simple with no infrastructure destruction, and the complex is with infrastructure destruction. The medical disasters can be divided into 2 types: external disaster and internal disaster. The external disaster mean external disaster is a major incident happening outside the healthcare facility. So the healthcare facility will start to respond to any disaster outside its vicinity. The internal disaster means the disaster itself affected the healthcare system itself or healthcare facility. So the healthcare facility will not respond and will start to seek for help. So we have 2 types of medical disaster depending on the location related to the healthcare facility or healthcare system. Okay. After that, we have some uh, examples of external disaster, like major RTE, like extreme weather, terrorism, war, biological, chemical, radiation, or outbreak, and the internal, like fire, hazardous spill, kidnapping, aggression, assault, bomb threat, explosion, hostage situation, or loss of critical resources. All these types of internal disaster can happen inside the hospital or inside the healthcare facility. Okay. Okay, how to manage a disaster? We have 4 phases of management. The first phase is called the preparation phase. The preparation or the preparedness phase consists of 2 major issues. The first is the planning, and the second is the training. To put a plan for disaster management and to train your staff on this plan. This is the preparedness phase. Then, and for sure, the preparedness phase is before the disaster. The phase after that is the phase of the response to the disaster when it started already. So the response phase, your plan will focus on the response mainly, how to respond effectively to this disaster when happening, and what is your role, what is the other's role for this disaster when happening. So training and planning is the first phase, pre-disaster phase. Then response phase is the second phase. After that, we have two more phases. One phase is the recovery phase, when the facility or healthcare system will start to recover or start to its a normal situation. And the last one is the evaluation phase. You will evaluate your response and if it was good or need some improvement. Usually after every disaster, if you are involved in any disaster response, you should update your plan after the disaster immediately. Even if you have this plan for 2 months only, يعني you build the plan 2 months ago and you have disaster today, after the disaster finish, you should update your plan according to the evaluation of the response phase. Okay, so as we see here, preparedness, planning and training, response, internal, external, and rescue and reception, recovery, and evaluation. Okay. We will not go deep for these slides. We will focus here on the response. The response phase have what's called systematic approach. How to respond to any disaster, there is systematic approach. It is called CSCA triple T. CSCA triple T. It is in this order, it is arranged in good order. Command and control, safety, communication, assessment, then triage, treatment, and transfer. For sure, the first four steps are managerial or administrative phases: command and control, safety, communication, and assessment. And the last three steps are mainly medical. So triage, treatment, and transfer are done by the medical staff. Okay. We will not go deep for internal disaster, as we will mention some points only, and we will focus on the external disaster and triage. Same order, command and control. Once we have some major issue inside the hospital, we have some emergency codes, and we will mention them at the end of the lecture. The emergency codes can be security codes and can be maintenance codes and can be safety codes. The internal disaster. Something like fire, code red, something like hazardous spill, code orange, and something like hostage, code white, something like that. So if you have the same this major incident inside your hospital or inside the facility, will be announced and you will start to evacuate the area according to the command of the command center. The command center at that time will be formulated with the senior manager at that time in the hospital and the seniors of the hospital with the head of the maintenance, the head of the senior engineer, the senior safety officer, and the senior physician. This committee or this command center will lead the response. For sure, the safety is major issue if you have internal disaster, to have your protective equipment, to to keep away from danger, and to save your life first, then the life of your team and you and the patients, and then you can save the documents, the equipment, or the facility itself. The major commander in this time is the safety commander. Sometimes it is the fire defense, fire team, or civil defense team. They will be the commander in this time, and you should follow their recommendations. Okay. At that time, if you have victims, from that event inside the hospital, you will create another area for assessment and treatment. Sometimes it is field hospital, sometimes it is another clinical area. If the area affected is not clinical, you can shift to the clinical area to make triage, treatment, and transfer of case. Sometimes the whole hospital will be affected, like the um, electrical failure. The whole hospital will be affected and it will stop working. So the whole hospital will start to evacuate and will start to seek for help from other facilities. No shelter or no field hospital can be operated at that time. For sure, if you build another area to take care of patients or victims, you will do some treatment and you will think about transfer. The major issue in the internal disaster is the need for evacuation. If you need to evacuate, you have some types of evacuation. The evacuation in horizontal way from the same level, in the same level, or in the same floor from the area of danger to safe area. Then the vertical evacuation from unsafe floor to safe floor, even up or down. You can, if you are in the first floor, you can go down to the ground floor or you can go up to the second floor. It is not necessarily to evacuate down. Sometimes the evacuation will be up and the rescue will be from the ceiling, from the roof floor, not the ground floor. Or from unsafe building to safe building, like in our hospital, if we have building at risk, you can evacuate that building to outside to the assembly point or to another building to safe building. Or if you have risk in the entire facility, you should evacuate the entire facility to outside the borders of the facility, like outside the gate of the hospital or the gate of the facility. This is the four types of evacuation. For sure, we have some to consider to have shelter in place. Shelter in place is to create a clinical area or safe place inside your affected facility to save the victims or to continue giving care to your patients. This is some example of the shelter in a big uh, in a big place, and I think you see this photo or similar photos during COVID in the time of isolation. Okay. A shelter should be away from danger and safe from weather change and have some vital resources. In the external disaster, the situation is different. In the external disaster, the risk or the major incident is located outside the facility. So the hospital or the healthcare facility will respond to this threat to save lives. So we have two ways to respond. One way is to send mobile emergency teams to the scene to save the patients there or to receive victims from the scene inside your hospital. Usually, the sending hospital or the sending facility is not the receiving facility. The Any hospital cannot do the two rules at the same time. They cannot send mobile teams outside the hospital to rescue the victims, and those teams will shift the patients to the same hospital. It should be another hospital as to save some stuff. If you send some mobile teams, you will use some stuff of your hospital. So the remaining stuff inside the hospital is not enough to receive the coming victims. So the rescue hospitals are usually different than the receiving hospitals. Same response phase, CSCA triple T. We will not go deep in the reception, in the rescue phase. We will go directly to the reception phase, as it is our core point in this presentation. Okay, the triage, we have two types of triage during disaster. It is totally different than the daily triage in the ER. The triage during disaster has two types. And the first type is the primary triage or the sieve triage. It is done by a medical or non-medical officer at the scene, and it will originate four colors: red for emergent, yellow for urgent, green for stable or less urgent, and black or white for dead victims. This type will be done in the scene of the disaster. At the reception phase, in the reception phase, you will do another triage at the gate of the hospital or the gate of ER, and it's called secondary triage. Should be done by medical staff, well trained, and the short triage will use some clinical tools like the systolic blood pressure, like the Glasgow scale, and the respiratory rate. Okay, so initially the primary is sieve triage, less precise, more fast, according to solid rules, and the secondary more precise, time consuming, using medical measures. The primary triage, as we discuss, we have this chart. First of all, the commander inside at the scene will make something called voice triage. He will shout for the victims, if you can hear me and you can walk, please come to my voice. So if he can hear, it means he is conscious. If he can walk, it means he is more or less stable. So he will get green, and he will go to the voice to be transferred to the hospital with any mean other than the ambulance. If the patient is not walking or not hearing or not understanding or not conscious, it will be a scene in his place. You will go to any patient. First of all, you will check if this patient is breathing or not. You found the patient not breathing. Open his airway by simple maneuver. Still not breathing, so he is dead. He's black. So don't offer him any medical care at the scene. So if the patient is not breathing, you open the airway and he started to breathe, so he will be immediately red. Okay. You find the patient breathing from the start. You will start to count the respiratory rate. If the respiratory rate is less than 10 or more than 29, he is still red. If the respiratory rate is between 10 and 29, we'll go to check the pulse or check the capillary refill time. If the capillary refill time is more than 2 seconds, or the pulse rate is more than 120 per minute, this patient is red. If not, the patient is yellow. That's all. Green from the start, if walking. Black from the start, if not breathing after you open the airway. Then every patient will be red unless he has normal respiratory rate and normal pulse rate, he will be yellow. This is what's called primary triage. The secondary triage will use what's called revised trauma score. This is the element of revised trauma score: systolic blood pressure, respiratory rate, and uh, uh, and Glasgow coma scale. As you see here, If the Glasgow is 13 to 15, he will get 4. If 9 to 12, he will get 3. If 6 to 8, he will get 2. If 4 to 5, he will get 1. If 3, he will get 0. Also with the systolic blood pressure and the respiratory rate, and you will count the score for every item, and you will find the full score is 12. 12 means he is green. Normal in Glasgow coma scale, normal in systolic blood pressure, and normal in respiratory rate. Okay, so green will get 12, yellow will get 11, and below 11, 1 to 10, you will be red, and 0 for sure for black. It is simple, but needs some clinical tools. For sure, if you did the triage for any patient, you should label him or put for him a tag with the color of indicating his level of triage. So the red will be with the red color. Whatever, you can use tape, you can use uh, paper, colored paper, you can use specific triage card, whatever, you should label the patient in his color. Okay, these types of some types of triage tags or triage cards. Okay, for the external disaster, the reception phase, if you start to receive the patient inside the hospital, we have some different issues, but we will follow the same steps, CSCA triple T, and we'll focus on triage, treatment, and transfer. For sure, the Saudi Health Council, they changed the color of the disaster code of reception phase inside the hospital. It was code green, it changed to code yellow. You will build a command center for sure. This is the members of the command center. Initially, senior manager, senior physician, nursing supervisor, and senior emergency physician. Then it will be hospital director, medical director, head nurse, and ER director. The code, when you have disaster inside the hospital, receiving victims or waiting for to receive victims, you have two types of code. Code yellow standby, if you have the alert to prepare yourself to start receiving victims, it's called a code yellow standby. No victims yet arrive to the hospital. Once the first victim arrive to the hospital, you will announce for code yellow activate. Okay, so it is different. And after you finish, you will announce for code yellow clear. Make sure you have your PPE. Make sure your safety is your first priority. Make sure you are working in a safe place. For communication, you can use many means of communication like the Bravo, the radio, the mobile phones, and the overhead system. And you should have your action card. You have already some action cards. It will appear like that. In the front, you have no name. You have the position and the location, and the color of the card will indicate if this person is key person or not. And in the back, you have some task to do. I think it's better to have some serial lectures in disaster management, as today we discussed only the basics in brief, and you will have further detailed lectures related to disaster management. Last thing to discuss here is our emergency code. Okay, here is our emergency code. As you see, the first line are called safety code, the safety and maintenance code, and the second row are security codes. Then the bottom 6 are medical codes that needs medical attention or medical response. Okay, we are done already. If you have any question, you are welcome. Thank you so much.